angioedema. Agenda: angioedema, types of angioedema, hereditary angioedema, including types, different clinical presentations, diagnosis, and management. The objectives: signs and symptoms of hereditary angioedema, lab investigation that differentiate various types of hereditary angioedema, compare the pharmacological strategies for the prophylactic treatment of hereditary angioedema, and individualized treatment plans for prevention of hereditary angioedema for the best to provide the best guidelines and recommended care for children with hereditary angioedema. Angioedema. What is the clinical presentation of angioedema? Angioedema, relatively rapid onset, starts within minutes to hours, frequently asymmetric in distribution. Distribution is not in the dependent area. It is not like heart failure. It is manifested in the eyes, or it's not like renal failure presents in the eyes, or in heart failure presenting in the legs. No, distribution is not in the dependent area, as you will see next soon. It is one of the top 3 conditions that resulting in hospitalization. Can you see this angioedema in the face? This is facial angioedema. And this is the cutaneous angioedema. It is non-dependent area. It is localized and mostly asymmetric in distribution. Can you see this? This is edema of the ileum, and down is normal ileum. And one of the serious manifestations is intestinal angioedema. If you can imagine that intestinal angioedema can be confused with intestinal obstructions, sometimes or acute abdomen, and sometimes the surgeon open the or do an surgical intervention as it is appendicitis or the intestinal obstruction for the severity of the pain, although it is not. It is intestinal angioedema. It is one of the serious manifestations of hereditary angioedema. Causes of angioedema: either allergic to food or drugs or insect bites, non-steroidal anti-inflammatory or contrast media, aspirin, ACE inhibitors, or idiopathic histamine-induced or mast cell-mediated bradykinin-induced C1 esterase inhibitors deficiency, type 1 and type 2, or acquired, or hereditary with normal C1 esterase, which is type 3. Etiology of angioedema: two types, mast cell mediated or bradykinin mediated. The mast cell mediated, there is a release of mast cell mediators, which is histamine, as all of us know, leukotriene C4, prostaglandin D2, heparin, and 90% are associated with urticaria and or pruritus, and there is a good response to antihistamine. In the bradykinin type of angioedema, there is a generation of bradykinin and complement-derived mediators increase vascular permeability, but there is no urticaria, nor pruritus, and no response to antihistamine, nor steroids, nor adrenaline, as all of us use to treat edema or allergic reaction or urticaria. Major types, as we mentioned, mast cell, bradykinin mediated. Mast cells starts within minutes to hours, and there is an urticaria, and there is pruritus, and there is a good response to histamine, and there is a good response to steroids. But bradykinin mediated, longer duration, takes hours, and there is no urticaria, no pruritus, no response to antihistamine, no response to steroids, and maybe pain or burning sensations. Hereditary angioedema is a fatal genetic disorder associated with either deficiency of C1 esterase inhibitors or dysfunction of C1 esterase inhibitor. Dysfunction of C1 esterase inhibitors mean the value is normal but not functioning as it should be. It is characterized by swelling involving deep nerves, and it is usually or generally localized, not systemic, associated with burning sensations and no intense pruritus lasts from hours to several days, actually from 2 to 3 days. Is it a new issue, hereditary angioedema? No. If we see this slide, we can see Osler. Osler, he died in 1924, and he's born in 1827. He said, hereditary angioedema is the affection of the family which I have studied have the following characteristic: the occurrence of localized swelling in various parts of the body, face, hands, legs, genitalia, buttocks, and throat. In one instance, 2 deaths resulted from sudden edema of the glottis, and this is the most serious complication. Associated with edema, there is almost invariable GI manifestation, either colic, nausea, vomiting, and sometimes diarrhea. And there is a strong marked hereditary disposition, and the disease having affected members of the family in 5 generations. And this was in 1888. Can we imagine? Long time ago. So it is an old issue, but and everything has been identified. For example, the defect biochemically is deficiency of C1 esterase inhibitors. And this is published in the American Journal of Medicine in 1964. So maybe 60 years ago. And the title of this paper was Biochemical Abnormality in Hereditary Angioedema. Epidemiology is an autosomal dominant. The estimate is not actually known, but maybe 1 in 30,000 to 1 in 80,000, approximately 1 in 50,000. No known ethnic or gender differences. And average attack frequency in untreated patients, 1 episode every 2 weeks or twice per month. But disease severity is actually highly variable between patients and within the same family. No, we cannot say. We can say that there is no simple relationship between the disease severity and C1 esterase level, C1 esterase inhibitor level. Age at onset, approximately 11.2 years. One of the most serious manifestations of it is abdominal attacks. And actually, it occurs in 93% of patients with hereditary angioedema. Mild to severe attacks of severe intolerable pain simulate acute abdomen. Sometimes it looks like internal obstruction. Vomiting, constipation, diarrhea may occur. Manifested as internal obstruction, which is very serious. With the fluid losses may lead to hypovolemic shock, abdomen distension, tenderness, and even reboundness. Symptoms may mimic surgical emergencies, and this result in misdiagnosis and unnecessary surgery. The second most important complications or manifestation is laryngeal edema. Laryngeal edema might cause death. A lot of people may die from laryngeal edema, and we don't know why did they die from. But what are the triggers of hereditary angioedema? Number 1 is trauma. 40% of patients can identify the cause as a physical trauma, maybe surgical or medical or even dental procedures, infection, emotional stress, medications as ACE inhibitors, or contraceptives as estrogen. And because the estrogen increase attack severity and frequency. And this is a function of C1 esterase inhibitors. And we will then go through, it's clear from this chart. And this is endothelial activation by bradykinin, and the result is vasodilation, increased vascular permeability, which consequently leads to angioedema. Hereditary angioedema, as mentioned before, genetically inherited form, result from increased generation of bradykinin due to contact system plasma kallikrein system activation. What are the types of hereditary angioedema? We have type 1, type 2, type 3. Type 1, which is the most common, represents 85%. And type 2, 15%. And the other one, we can maybe call it type 3, rare. In type 1 and type 2, C4 is low. In type 1, C1 esterase inhibitor level is low, but in type 2, it is normal. And this also demonstrates different types. The first one, type 1, is representing 85%, and the second one is representing 15%. And it is due to C1 esterase deficiency or dysfunction. And this is good algorithm for diagnosis of hereditary angioedema. If we have episodes of angioedema without urticaria, episodes of abdominal pain, and or vomiting or laryngeal edema, and there's a family history of hereditary angioedema, and if any of these signs or symptoms, we have to think of hereditary angioedema. We have to measure C4 to screen for hereditary angioedema. If it is low, we have to measure C1 esterase inhibitors. If it is low, this is type 1. If it is not low, it is type 2. If both are normal, this is the rare type, or sometimes we call it maybe type 3, or consider other etiologies of hereditary angioedema. Treatment approaches for hereditary angioedema. One of the most important point is treatment of acute attacks, which means termination of ongoing attacks, prevention of morbidity, which is more serious is prevention of mortality. Laryngeal edema may cause less because it obstructs the airway. And even when they come, there's an accident emergency, and there's an airway obstruction, and a lot of trials for intracranial intubation. Nobody can do it sometimes from the severity of the obstruction. And tracheostomy should be done. But so long nobody is aware of the condition, sometimes there may be eventually death. Long-term prophylactic therapy to prevent hospitalization, emergency department visits, and minimize attacks and frequency and severity of the hereditary angioedema manifestations. Pre-procedures, prophylactic dose for minor or major procedures to prevent the attacks of hereditary angioedema. And this is targeting the bradykinin. It is clear because it is the ultimate outcome is angioedema. Management. Number one is patient education counseling. Patient education, the most important item to avoid the triggers we mentioned before, trauma, infection, stress, etc. Treatment of acute attacks, and short-term pre-procedure prophylaxis, and long-term, as we mentioned later, long-term prophylaxis as well. General rules. C1, sterase inhibitor concentration, either plasma-derived or recombinant, are the main lines of management. No role for antihistaminic, and antihistaminic shouldn't be tried. However, they may be used to differentiate at the beginning if we are not certain, or if we don't know that this is hereditary angioedema or it is allergic reaction, to differentiate between histamine and non-histamine mediated angioedema. Histamine mediated will respond to antihistaminic, but non-histamine in our issue wouldn't respond to angioedema. So hereditary angioedema wouldn't respond to antihistamine, but antihistamine will help us to differentiate between the two. No role for corticosteroids, no role for adrenaline or epinephrine. Other medication as androgen, bradykinin receptor antagonist, and kallikrein inhibitors are used in different situations with special or different indications. We have to remember, treatment should be started immediately as prodromal symptoms starts to appear. And we have to know that laryngeal attacks are life-threatening. Ventilatory and circulatory support and ICU should be immediately available for these children or this patient with hereditary angioedema. And these are the drugs, list of the drugs that is approved by USA, by FDA in the USA or EMA in Europe, and each one by age. Long-term prophylactic treatment. Does the patient require long-term prophylactic treatment? Actually, not all hereditary angioedema patients require. The guidance recommend discussing options with patient at each visit. Need different by different individuals, frequency and severity and type of attacks and availability of care and failure on-demand therapy. Modalities, C1 sterase inhibitors replacement, either intravenously or subcutaneously, plasma kallikrein inhibitors, anabolic androgens, and antifibrinolytic and progesterone or progestin. Those are the factors. These are long-term prophylactic treatment. And these are the prophylactic therapy in this table. All the societies in the world, they agree to the guidelines on management of hereditary angioedema, either in USA or World Allergy Organization, in Europe, anywhere. And there's specific indications for prophylaxis. Number, routine prophylaxis versus acute treatment. It depends on the nature of hereditary angioedema symptoms, frequency, severity, and anatomic locations. For example, for the frequency, rapidity of onset and progression, severity loss, level of functional impairment, anatomical location, degree of psychological, and the degree of psychological impact as well. The availability of rapid and acute treatment plan, impact of hereditary angioedema on work or school. Because, for example, if somebody who has getting edema in his face or hands or feet, he wouldn't go to work. Restoration of normal daily life. Individualization. Management of hereditary should be individualized. Patient factors, attacks frequency, rapidity of progression, laryngeal attacks, access to medical care, history of frequent hospitalization and treatment medications. Regarding the medication factors, efficacy, safety, patient tolerability, route of administration, location of administration, sources, and cost. These are the factors which concern with the medications. component of comprehensive treatment plan for new medications in hereditary angioedema or modern hereditary angioedema. Acute treatment plan for every patient, routine prophylaxis in some patients, logistic treatment plan, recommendation of involvement of hereditary angioedema specialists when possible, monitoring the efficacy and side effects. There should be hereditary angioedema action plan, which includes letters, parcels, USB drives, electronic medical records, monitoring the efficacy and side effects. We have to know what is known and what's unknown regarding the risk of medications, androgens, plasma products. It is not only plasma products, it is fresh, it should be fresh frozen plasma to include complements or C1 esterase inhibitors. And long-term safety of monoclonal antibody, local and systemic treatment reactions, intravenous access, individual patient variability in response to therapies. Hereditary angioedema is a complex issue and highly variable chronic condition, and there should be monitoring for these patients. Prevention or special issue. For example, for children, vaccination to avoid infection, avoid estrogen containing contraceptives, progesterone only, educate patients, family, caregiver, and educators. A pregnant woman, pregnancy may aggravate sometimes have no effect. Selection of medication, we have to go through safe pathway for pregnant women. Now I will go to case report for a patient, for a child with edema, and we'll go forward step by step. Layla is 7 years old, girl, first-born child, born by cesarean section, consanguineous parents, developmentally actually shows normal from the beginning. Vaccinations up to date shows normal till the age of 5 years. I'm sorry. So I will cite for the case report once more. I'm sorry for this interruption. 7 years old girl, cesarean section, consanguineous parents, developmentally normal, vaccination up to date, shows normal till the age of 5 years. She wasn't receiving any medications, but she has an episodes of swelling of different parts of the body. And this swelling is painless, not itchy, no redness, no hotness, no rash with attacks. It includes upper and lower limbs, face and abdominal wall. It was self-limited for 1 to 2 days, but recurrent twice per but it was recurrent every 2 to 3 months. Trauma and insect bites, this was always what doctors says, or the patient, or the families, or caregiver, or mother sought. Antihistaminic and steroids used, prescribed, but no response. And this is the picture of the angioedema of the face for this child. No history of similar condition in the family. Father was diagnosed as FMF, and he was put on colchicine. But is it really FMF? It was diagnosed by symptoms. The symptoms mainly was abdominal pain. I don't believe it was FMF. It was actually hereditary angioedema of the father as well, but not diagnosed. Investigation for this young lady, Laila. C4 was normal. C1 esterase inhibitors was low. I'm sorry, C4 was low and C1 esterase inhibitors was low as well. So the diagnosis was made hereditary angioedema type 1. Then you how to manage Laila. Recently, in Egypt, Sunrise is available now, maybe even last month. Sunrise is plasma-derived C1 inhibitor that increase the level of C1 inhibitor to prevent generation of excess bradykinin, and thereby treating and preventing hereditary angioedema. The indication, treatment and short-term prophylaxis of hereditary angioedema in adult and adolescent children more than 2 years with hereditary angioedema. Routine prevention of hereditary angioedema attacks in adult, adolescent children more than 2 years with severe and recurrent attacks. Mechanism of action, suppression of contact system, activation by C1 inhibitors, so the inactivation of plasma kallikrein and factor 12, active factor 12 is thought to modulate this vascular permeability by preventing generation of bradykinin 2. The route of administration is intravenously given. Dose, the recommended dose for children more than 2 years, 2 to 11 years, and weight from 10 to 25 kilogram is 500 units, which is 1 vial of Sunrise should be injected at when we see for the immediately swelling attack. Second injection, which is also 500, may be given if symptoms doesn't improve within 1 hour. But if children more than 2 years, 12 years, or above 25 kilograms, doubling the dose. 1,000 international units instead 500 international unit with the same would be repeated within 1 hour if no improvement of the edema or the attacks. Prevention of swelling, dose of 500, which is a vial of Sunrise, should be injected up to 24 hours before medical or dental or surgical procedures, and double the dose if child is more than 12 years or above 25 kilograms. Routine prevention from 6 to 11 years or from 10 to 25 kilograms, also 500 international units should be given every 3 to 4 days for routine prevention of swelling. The dose may be adjusted according to the patient response, and if he is 12 years or above 25 kilograms, the dose should be doubled. When we have to suspect hereditary angioedema edema, if there is a recurrent episode of angioedema without urticaria or pruritus, number 1. Number 2, if there is an unexplained recurrent episode self-limited bulky abdominal pain. Number 3, if there is an unexplained laryngeal edema, even with a single episode, because it is a very serious and it is fatal condition. Angioedema episodes in the absence of angiotensin converting enzyme inhibitors, non-steroidal anti-inflammatory drugs, or history suggestive of allergic cause, family history of angioedema, low complement C4 level in patient with angioedema, and the history of no response of trial of antihistamine or steroids or adrenaline or epinephrine, we have to suspect in all this condition that this patient might have or might be diagnosed hereditary angioedema. Although about 25% of patients have no family history of hereditary angioedema. Thank you very much. And this is my hospital. Thank you very much indeed. Thank you very much for your attention and your listening. ألف شكر.
متعة. Thank you very much, Professor سامح. ما أعرفش مين معانا الحقيقة.
دكتور ولاء.
Thank you very much. Very nice presentation الحقيقة. وبس عايز أقول إن hereditary angioedema is now increasingly recognized. يعني ما بقتش يعني حاجة so rare، لكن هي increasingly recognized، والclinical suspicion دلوقتي فيها بقى is high. We can diagnose a lot of cases دلوقتي. أنا بس ليا إذا كان كومنت صغير على هل في رول يا دكتور سامح بيه للأندروجينز في المانجمنت زي دانازول مثلا أو اكسندرولون؟
يعني هو يعتبر لاين من اللاينز القديمة، مش الحاجات الجديدة. ودي
تمام. الجديدة خلاص حضرتك قلتها. أنا بتكلم ستيل في رول للحاجات دي.
يعني أنا بالنسبة لي بعتبره هيستوري. يعني أنا بقى it is not an easy to give androgens children،
خصوصا في الأطفال.
بالضبط، عشان السن كمان.
في الأطفال تحديدا صعب.
يس تمام. ثانك يو فيري ماتش. وانا بحيي الدكتوره سلمى، انا شايفها معانا. بروفيسور سلمى، جود مورنينج.
دكتور ولاء، في اي حاجه حضرتك تحبي توضحيها يا دكتور ولاء؟
انا متشكره جدا لحضرتك على الديتيلد ليكتشر بتاعت الهيريديتري انجيوديما، وعلى الجود نيوز اللي فيها في الاخر انه في دراج اباوت تو بي موجود في مصر. زي ما حضرتك وضحت، I think ان احنا we still lacking النولج بتاعت الفيزيشنز، especially الفيرست لاين فيزيشنز الموجودين في الطوارئ وفي الاي ار عن التايبس اوف hereditary angioedema او types of angioedema و how to approach the details of angioedema. I think ان مزيد من هذه المحاضرات محتاجينه اكتر علشان يبقى في awareness بس بالdifferent forms of angioedema وبالdifferent lines of management زي ما حضرتك قلت.
يعني دكتور لا بعد اذنك، انا بالنسبه لي يعني هو rare.
Yeah, it is rare.
ولكن المشكله عندنا ان العين ما بتشوفش اللي المخ ما يعرفوش.
Exactly.
اول خطوه احنا بنعملها ان احنا بنحاول نعمل awareness.
Yes, to raise the awareness. مظبوط.
دي اول حاجه. لما بنعمل awareness بيبدا تظهر الحالات، يبقى على بال بدل ما تقعد مع الدكاتره الجنرال او الاخصائيين شهور، مش عايز اقول سنين، وحالات الشخص FMF wrongly diagnosed FMF، وحالات كإنسان obstruction and it is not inside obstructions. This area should be, we should stop these things. We have to increase awareness, knowledge, and when to refer and when to suspect.
And the immediate management. لازم كل physician بيقف في طوارئ يبقى عارف how to do the immediate management لأنها life threatening condition.
Yes. يعني أنا مش عايز أقول one of يعني واحد من أهل البيشنتس يعني he died at the age of 25 years.
Yes, I know.
وما كانش حد عارف هو died ليه، بس هو جاله سترايدر and died. والكلام طبعا اللي بيكتب دايما he died من هبوط حاد في الدورة الدموية التنفسية.
محدش عارف.
لكن what is the underlying pathology? What happens? Nobody knows and nobody cares. But now we know that when this child was diagnosed, that her father has hereditary angioedema. So
احنا كل الاولاد عندهم family history of death. يعني الحاله مامتها توفت، اخوها توفى to an attack. فطبعا يعني ده كاتاستروفيك لايف ستايل بالنسبه لهم، ان هم يبقوا مهددين ان اي واحد فيهم يصحى من النوم بسترايدر ويجي له فيتال اتاك. فلازم يكون عندهم الميديكيشن ات هاند ياخدوها وقت النيد.
حضرتك متوقعه الانسيدنس يكون حوالي قد ايه دكتوره ولاء؟
It is still rare, very rare. يعني احنا ممكن نبقى زي الانسيدنس العالميه في الراريتي بتاعتها.
يعني 1 في 50,000 ولا 1 في 80,000؟
لا I guess less than this.
يعني 1 في 30 اللي هي الفيجر.
لا I mean less frequent than this. One in each 100,000.
اوكي.
I guess so. لانه احنا في السنتين اللي فاتوا كنا بنحاول نتريس الكيسز. برضه التايب 1 مش ذات كومن، مش هو الموست كومن وكل حاجه، بس we don't have so much cases yet.
اوكي. هو طبعا انا متوقع يعني I know it is rare، ولكن دايما بقول لنفسي rare but it is there. But
it is there, and if we consider type 2 and type 3 it will not be rare.
Yes.
We can only so far diagnose type 1. So type 2 and type 3 are missed. Still missed.
هو طبعا الحاجه المهمه يا دكتور ولاء seriousness of this disease. الفيتال complications، الفيتال condition، الابدومين acute abdomen surgical intervention لchildren who مش محتاجين.
Exactly.
بطنهم تفتح.
And what's more important that it can be saved. Lives can be saved. So ما نقدرش نقول ان هو عشان rare خلاص هم they died to a rare disease. There's something readily available can be done for them.
Yes. واحنا لاقي طبعا ان الدواء نزل اعتقد بقاله شهر يا دكتور ولا؟
بقاله شهر خلاص. It's about ان هو يبقى في التأمين الصحي ان شاء الله.
لا انا بتكلم يعني عندنا في وزاره الصحه، يعني عندنا في مصر ابروفد من شهر وافيلبل.
ابروفد دخل مصر خلاص من شهر فعلا، لكن هيبقى افيلبل في التأمين الصحي كمان في الانشورنس في خلال الشهرين اللي جايين ان شاء الله.
اوكي.
بس الدواء موجود يعني ممكن اي حد يجيبه.
اوكي.
Good news والله بروفيسور ولاء وبروفيسور سامح. Good news ان يبقى عندنا الابديتد مانجمنت of this disease الحقيقه.
يس جود ان احنا نلاقي التريتمنت ات هاند وقت ما نحتاجه نلاقيه فعلا.
شور.
يعني من هو التشخيص كان في الستينات وكتب عليه من 1800 وكذا، انا مش فاكر بالظبط، ولكن يعني حاليا الدنيا طبعا ديفنتلي بيحصل تشينج كل شويه والثانيه في يعني في الدايجنوزس والمانجمنت اويرنس، وكل ما تزيد سواء الاويرنس النولج البراكتس هيتحسن في الحقيقه دكتور ولاء،
ان شاء الله طبعا
in the near future باذن الله.